attendees. Welcome to our scientific webinar, which is held as a part of international scientific webinars in a cooperation with Jordanian Ophthalmic Society and Novartis. And today it's my honor and my pleasure to invite one of the eminent speakers from Italy, Professor Massimo Nicolo. Professor Massimo, it's a professor and clinical ophthalmologist at the University Eye Clinic, Genoa, Italy. He completed his ophthalmology residency and obtained his PhD at the University of Genoa in 2000. He completed a research fellowship in molecular biology of the retinal disease at the New England Eye Center, Tufts University of Boston, United States. And his main interest including the retina, vitreous, and imaging techniques. He authored several publications in peer-reviewed journals. And today we will discuss one of the important and debatable subject, is the chronic central serous retinopathy. And before we start our webinar, if you have any question, please put your questions in the chat. And after each case, we will take a couple of questions. Professor Massimo, the stage is yours. Welcome.
Okay, thank you. Thanks for the kind invitation, Fawaz. I'm honored to be with you today in this very atypical case due to the COVID-19 problems that is involving all of us. So thanks also to Novartis to have sponsored this webinar, and thanks to all the eminent colleagues that are now watching this webinar. So I was invited to talk about a disease which I'm familiar with, and this disease is the central serous retinopathy, CSC. I will show you 11 clinical cases, acute, recurrent, chronic clinical cases, complicated by neovascularization. We'll see them, and I will try to explain my experience with these cases and how I'm used to manage these cases. So I will, if you agree, I will start with the first clinical case. This is a male patient with, as you can see, a subtle subretinal detachment. There is a thick choroid. We were on September 2018. In that case, I was not very interested in treat this patient. I tried to postpone the treatment. So I saw the patient again on January 2019. Actually, I asked the patient to be visited again after 1 month, but as you can see, the 1 month became more month. Anyway, when I saw again the patient, the fluid was still there, and we were on January 2019. There was a subtle also retinal pigment epithelial detachment, which can be seen in the magnification of the OCT scan. For this reason, because the subretinal fluid was persistent, I decided to do fluorescein angiography. And fluorescein angiography, as you can see, showed as the typical defect of the RPE and the leakage of the fluid from the early, intermediate, and late phase. So, what to do in this case? This is a persistent subretinal fluid, and the diagnosis is central serous retinopathy. I'm not used to wait too much. and I'm not used to tell the patient wait and it will reabsorb and the fluid will reabsorb. So I decided to treat the patient and to use photocoagulation. Why I used photocoagulation? Because it was an acute case. There was a single RPE defect very distant from the fovea, and the RPE was around the RPE defect was in healthy state. So I decided to do a very small and very gentle and subtle focal photocoagulation. I'm used to use now the 577 nanometer yellow laser, but we can also use other kind of laser. And the important thing is not to coagulate the tissue, the retinal tissue, but just using a very gentle energy, just to see some grayish of the and not a whitening of the tissue. And then I follow the patient. This is the first follow-up visit, March 1st, 2019, after the photocoagulation. You see that there is a complete resolution of the fluid, and you also can see the hyperreflective presence of the laser beam at the level of the outer nuclear layer. But I mean, there was no adverse events in visual acuity. Visual acuity was 20/20, and the patient had no adverse event. This is after another follow-up visit, January 2020, and again there was the persistence of the complete resolution of the subretinal fluid. So this kind of treatment was, to me, a success. Second case, male patient with ankylosing spondylitis, and for this reason he was on steroid treatment. We were on September 2013, visual acuity was 8/10, and there was subretinal fluid. Subretinal fluid due to a RPE defect that you can see on fluorescein angiography, and indocyanine green angiography showed a subtle and light hyperpermeability of the choroid. What to do in this case? In this case, I decided not to wait. Why I didn't wait? I didn't wait because this patient was on steroid treatment, and he can't stop the treatment because of the systemic disease. So it was not supposed to have in the future more probabilities to have a spontaneous resolution of the fluid. So I decided to treat at that moment the patient again with laser photocoagulation, because there was a single, very extrafoveal point that was the origin of the fluid. This is 1 month, 2 months, 4 years after laser photocoagulation, and there was the persistence of the complete resolution of the patient. The patient was happy, and visual acuity was completely restored. But pay attention, because there was a recurrence 5 years later. Again, subretinal fluid, and again, the same RP defect was reopened. And again, I decided to treat with laser. And there was a complete resolution. So in about 5-6 years, this patient was treated twice with laser photocoagulation, just a few spots of laser aiming to create a grayish reaction, not a whitish reaction of the retina. So do you have any questions? Fawaz?
Okay, Professor Massimo, now the message from the first case, it's very important that even in acute cases, you need sometimes to do the fluorescein angiography because the leaking point may be away from the foveolar vascular zone. That's why you can treat the condition just with a single shot of laser. So I totally agree with you because sometimes even we found that the leakage point is away from the foveolar vascular zone. But regarding your second case, is little bit, for me, it's difficult to give the focal laser in a such area which is very near. So I wish to ask you how to select the setting of the laser in this case, how you select the laser power.
Well, I start with the lower energy possible. So
okay.
I set the spot laser on 50 micron, 10 milliseconds of exposure, and an energy beginning with 50 milliwatts.
Okay.
And then up and then. 10 milliwatts until I see a very little and tiny grayish of the retina.
Okay.
When I see the grayish of the retina, I use like 5 spots, not more, and that's it.
Okay. Is there any place to use, for example, the micropulse laser in the second case?
Well, it might. I mean, it could be used in this case.
Okay.
I understand that the leaking point is not so far from the fovea, so there might be some problem, and someone can be afraid to do a photocoagulation so close to the fovea. So in this case, we can use also micro.
Okay. Okay. So any questions from the audience? We received just a couple of questions. Any questions from the audience?
Hello, Dr. Fawaz.
Hello. Yes.
Hi. There is more than one question in the chat.
Yeah.
The first one is from Hussein. Spot size used. He asked about the spot size used.
Yeah, I think Professor Massimo, he answered this question as 50 micrometer.
Yeah.
And what is the type of the lens? I want to ask, what is the type of the lens? I think the area centralis lens.
Iris centralis, right.
Yeah.
Iris centralis is the best lens. I mean, in my experience, is the best lens. I don't use anymore the Goldman lens.
Okay. Okay.
I was used to use it many years ago when I began at the beginning of my career. Now I use Iris centralis.
Any more questions? Please, any one of the colleagues who want to ask a direct question, he can unmute himself and ask Professor Massimo direct question. Okay, so shall we proceed? Okay, Professor Massimo, you can proceed with the third case and fourth case.
Third case. So the third case, this is the third case. So we were on July 2009. Again, this is a male patient with this clinical picture. There is a huge, important subretinal detachment of the macula by fluid. But in this case, with and you can see from the autofluorescence, there is a RPE disease. There are 2 hypoautofluorescence area here, and also there are hyperautofluorescent spots. That means that the fluid is there since many times. And you can also see that the outer nuclear layer are granular. There is a granular aspect. That means chronicity. Okay, so fluorescein angiography showed that in those 2 points there is a very faint leakage. Maybe it's not a very clear leakage. Maybe it's a kind of staining. We can see that is half and half. Probably now I will say that is most staining than leakage. But on 2009, I thought that those fluorescent pattern was predominantly leakage. So I interpreted those 2 points, and maybe I made a mistake, as the responsible for the leakage and for the fluid. So for this reason, I decided to photocoagulate those points, okay? With the same kind of procedure, small energy, small diameter of the spots, very small 10 milliseconds of exposure rate. And this was the effect after photoregulation. 1 month after photoregulation, you can see that there is a partial reabsorption of the fluid, not complete actually. 2 months, there was a complete resolution of the fluid, at least at the fovea, but there was still some fluid eccentric to the fovea. But after 3 months, there was a recurrence. So I repeated again fluorescein angiography, that was basically the same, but also indocyanine green angiography. And I didn't perform before indocyanine green angiography. And it was a mistake, because if I had performed indocyanine green angiography, I would have seen those 2 hyperpermeability areas of the choroid. That means that the CSC was on a chronic stage, because when at indocyanine green angiography you are able to see the hyperpermeability of the choroid, that means the choroid is very thick and is able to show the hyperpermeability on indocyanine green angiography. So in this case, the treatment of choice to me, and basically in Europe, is photodynamic therapy with a modification of the dosage. You can do it with a half dose or half fluence. It's almost the same, but the importance is that you perform PDT on the guidance of ICG, because you have to target the area of choroidal vascular hyperpermeability. I was lucky because Professor Cardillo Piccolino, who was one guy who was the first to, or one of the first to have used indocyanine green angiography, was in my clinic when I was at the beginning. So I learned from him many things. And this is a very brief. I have just one slide just to show you how was the beginning of the photodynamic therapy. It started on 2003, and how many papers on that matter was published in the other years, for a total of more than 300 papers so far. So today in Europe, at least, photodynamic therapy with a modified dosage is a very important treatment for chronic CSC. It's important to modify the dosage or the fluence of the energy, because otherwise, if you use standard PDT, you can have a persistent closure of the choroid capillaries with an irreversible decrease of visual acuity, and this is an important side effect that we have to avoid. In Genova, I'm used to use the half dose PDT. So I half the dose of PDT. Instead of 6 milligram per meter square, I use 3 milligram per meter square. Other colleagues are used to half the fluence of the energy. Okay. PDT half dose or half fluence is a safe treatment. There is no adverse events on the retina, on the RPE, and on the choroid. So let's go back to our case, third case. I decided to target these 3 areas of choroidal hyperpermeability with half dose PDT. And after 2 months, this was the result. There was a complete resolution of the fluid. Of course, autofluorescence still highlighted the areas of RPE disease there, and also those small hyper autofluorescence dots due to lipofuscin, due to the discs of the photoreceptor that was shed under the neuroepithelium. But who cares about this kind of pattern? The important thing was to have tried the macula in a persistent way, because I keep following, and after 8 years, the macula is still dry. And there are no new vessels, if you are interested in, as you can see by the OCT. So if there is any questions, I will proceed with the case 4. Case 4 was again a male patient, and this case is interesting because this patient is on 2009. He had around 66 years old, and he underwent in the years before to vitrectomy for a macular pucker. And after that, after a couple of years, he had central serous chororetinopathy. Fluid autofluorescence showed us several areas of RPE disease. Hypoautofluorescent, that means that the RPE is not healthy. So we performed the fluorescein angiography, which showed the RPE decompensation, and probably in this point, this was the point responsible in that day for the subretinal fluid. There is a leakage if you see the early, the mid, and the late phase of the fluorescein angiography. Here you can see the leakage. But again, if we perform indocyanine angiography, we see that there was a diffuse hyperpermeability of the choroid. So it was not advisable to perform photocoagulation on that point, of that leaking point, because the RPE was very diseased. So I prefer to do half-dose PDT on those areas, on those hyperpermeability of the choroid areas. And those was the results. 1 month after PDT, there was a complete resolution of the fluid, and I keep following this patient, and after 7 years, the macula was still dry. Okay, any questions about those?
Okay, just a question, Professor Massimo. So your preference in chronic cases of the CSR is to use the photodynamic therapy as the first option. And do you need always the ICG to take the decision for the photodynamic therapy?
Yes, basically, I perform always ICG.
Okay.
Not always. I will show you one case in which I didn't perform ICG and I didn't perform fluorescein angiography. But usually I do it.
Okay. So any questions from the attendees, from our colleagues? Please, if you want to ask, you can unmute yourself and ask if there is any questions.
Dr. Fawaz, we have one question on the chat, I think,
yes.
For the third case.
Yeah.
He's asking, Dr. Manjid, I think, asked about what kind of laser.
We already answered this question. It's yellow laser, 577, yeah.
Okay. Yeah, in acute case, yes.
Yeah. Any questions?
Dr. Fawaz, I want to ask the professor a question, please.
Yes.
My name is Dr. Uday Juma. Sir, in Jordan, we don't have the PDT. So what's the alternative for the chronic CSR cases if the PDT is not available?
Well, that's a very good point. Which is the alternative? Actually, you can use micropulse laser. I think that there is no other alternative. I'm saying that because it has been recently published a randomized clinical trial, the PLACE trial, in which it was half-dose PDT was compared to a micropulse laser. In that trial, half-dose PDT was superior to micropulse laser. Anyway, patients treated with micropulse laser did a very good job as well. So I think that the second choice, micropulse laser, could be a second choice, an important second choice. I'm not used to inject patients.
Thank you.
Okay, thank you. Any question from the audience? Please, you
Fawaz,
can.
We have another question from chat from Dr. Hussein.
Yeah, I saw the question, but I didn't understand. From what is presented, the leakage is from the margin. I didn't understand the question. Dr. Hussein, you can unmute yourself and ask the question directly.
Thank you, Dr. Fawaz. This is Dr. Hussein Zuwaidi from Iraq. From what I saw from the cases, most of the leakage is from the margin of the detachment. Yeah, the RP detachment, you see the dome and the margin is the leaking points. This is what I saw. And the other question was, when you do PDT, we're used to doing PDT for a single spot. How do you manage, giving the ICG, IV, and doing 3 spots at a time? How much time do you give for each one? Thank you.
Okay, so PDT is performed using a very large aiming beam. Basically, the one that I circled is the diameter of the aiming beam that I used, and the exposure time is 83 seconds for all the 3 points that I treated. And the important thing is to be sure not to be confluent. Otherwise, there would be chororetinal areas which received a double treatment, so a full dose treatment. Okay.
Okay. So we can. Thank you very much. We can proceed.
Okay, so case number 5. Case number 5 is a case that I saw for the first time in 2009. There is a fluid under the nerve epithelium, but also multiple RPE detachment, as you can see at the OCT. I performed fluorescein angiography and indocyanine green angiography, and in that case, you can see that there is a very, let's say, diffuse leakage in that area temporal to the macular area. There is a very huge amount of fluid inferiorly here, and indocyanine green angiography showed a very important areas of hyperfluorescence due to the leakage of the dye under the nerve epithelium, but also due to the hyperpermeability of the choroid. Again, in this case, I prefer to use half-dose PDT, and this was the results 1 month after half-dose PDT. You can see that there is no fluid under the nerve epithelium, but there is still fluid under the RPE. Usually, half-dose PDT, as well as photocoagulation or other kind of treatment, are not supposed to get rid of the fluid also from the RPE, under the RPE detachment. Is not that the problem. The problem is to get rid of the fluid from the under the nerve epithelium, and what we have done. So that's the reason why the RPE detachment are still there. So this is 3 months after half-dose PDT. Macula was dry, RPE detachment was still there, but patient didn't realize of the presence of the RPE detachment. And this is 2 years after half-dose PDT. Again, the macula was dry, but the RPE detachment was still there, and the patient was not aware of them. Case number 6. Case number 6 is a very, to me, was a very complicated case. Female patient, and you know that CSC is not so frequent in female, with a visual acuity of 20/80, so a significant decrease in visual acuity. The only eye, the other eye was amblyopic, a strong hypermetropia, but the important thing is the systemic disease of this patient: glomerulonephritis, congestive heart failure, and systemic arterial hypertension. For those reasons, the patient was administered in the years before with a high dosage of steroids. So OCT showed a very diffuse subretinal detachment. There is a thick choroid. There are choroidal folds due to the fact that the eyeball was short in length. And this is the fluorescein angiography that I performed with the California, with the wide field angle that we recently have the occasion to use. And what we see that there are multiple points of leakage, probably this one and this one, also this one were the more active leakage. But take a look to the indocyanine green angiography. Indocyanine green angiography showed a huge, several areas of choroidal hyperpermeability. So the choroid of this female patient was very thick and congestive. Why? Probably due to the shortage of the eyeball, probably due to the systemic disease, probably due to the fact that she was previously treated for the systemic disease with a high dosage of steroids. So what to do in this case? I thought when I first saw that patient that I had to use more than one treatment. For this reason, I first of all treated with laser those 3 points, 1, 2, and 3, with photocoagulation. I wasn't certain, and I was sure to not be able to get rid completely of the fluid. And as a matter of fact, fluid was still there, but decreased. If you compare the OCT 1 month after photocoagulation with the OCT before, there was still fluid, but there was a decrease of the fluid. After that, I performed half-dose PDT, guided by the ICG. Here, 4 spots. And this was the results. There was a complete resolution of the subretinal fluid. Yes, there was still a subretinal detachment, a tiny fluid, very long very far from the macula, that was still there after 5 months. But I think that we can also leave this fluid there. The patient was very happy. And I'm still following this patient, of course. If there are no questions, I can show you case number 7, which was very long and complicated cases, because this was an unusual case in which there is a subretinal detachment and of fluid of the nerve epithelium in the macular region, but there are multiple RPE detachment on fluorescein angiography. And on indocyanine green angiography, also there are RPE detachment, but there is also a diffuse area of hyperpermeability of the choroid. So again, in this case, I performed the half-dose PDT. We were on 2009. This is the follow-up visit after 6 months. There was a complete resolution, and I keep following the patient until December 2017, when the patient went back to my office because he had he developed metamorphosis. And as a matter of fact, there was a very important amount of fluid under the nerve epithelium, but not only, also under the RPE detachment. But take a look to the density, high density of the fluid under the nerve epithelium. You see that there are many hyperreflective spots within the fluid. That means that this fluid is rich of protein, of fibrin. And this is a very important point to highlight. So for this reason, I decided not to do any kind of treatment. So I just wait and see. The patient went back on March 2017, so after 3 months, 3-4 months. And the clinical picture and the OCT changed dramatically. There was no fluid anymore. There was no RPE detachment anymore. But fovea was involved, and there was a very thick presence of fibrin under the nerve epithelium. Okay. So when you see fibrin you have always to be afraid of it. Actually, in that occasion, I wasn't. And I mean, probably I didn't make the right decision, because I decided to treat again with half-dose PDT on that area. And after 1 month from the second half-dose PDT, because the first half-dose PDT was performed many years before, after 1 month after the second half-dose PDT, there was a coarctation of the fibrin. The patient had more metamorphopsia, and he was very concerned about it. Fortunately, the fibrin, the fibrosis was relieved spontaneously after a couple of months, and 7 months after the second half-dose PDT, metamorphopsia decreased and patient was happy. But I was very lucky, actually. So this is a kind of case in which if you want to do PDT, you have to pay very more attention. If you can avoid it, and if you have an alternative treatment, I say use it. Because there should be, as it was, some kind of adverse events.
Okay, so Professor Massimo, just a question here. So what do you recommend in case you're watching the fibrin, subfoveal fibrin? Do you wait and then, for example, 1 month, 2 months until the fibrin resolved and start the treatment, or you should start a different kind of treatment rather than PDT?
So in this case, if I had to go back and retreat and rethink another kind of treatment for this patient, I will give him a Pleurenon. Mm-hmm. I'm not a very good. I'm not use a Pleurenon anymore, actually. But in this particular case, I will try to use a Pleurenon. I think that doing micropulse laser probably the results might be similar with doing a half-dose PDT.
Okay. Any place for anti-VEGF?
I have no particular explanation why I choose a Pleurenon and not because I think that with a Pleurenon I can obtain many side effects, many local side effects.
Okay, so any place for anti-VEGF, for example, just to reduce the choroidal permeability and maybe reduce the leakage and the fibrin?
Well, I mean, this is a kind of case that it's open to any kind of treatment. You can also choose anti-VEGF. Yes.
Okay. Any questions from the colleagues? Please, you can unmute yourself and ask.
Dr. Fawaz, so I think I have a question.
Yeah. From Dr. Ahmed, any difference in treatment whether RP detach or not in the cases of CSR?
Okay, no. If there is RP, I treat RP detachment if there is detachment of the nerve epithelium.
Okay. The second question, I think we already answered from Dr. Gianni. The role of anti-VEGF in resolving CSR. I already asked this question, and yes, we may find some role of anti-VEGF in such cases. Okay, so any questions before we proceed to the case 7?
Good evening, Dr. Fawaz and Professor Massimo.
Good evening,
My
Dr.
question to Professor, yes, Mohammed Janabi from Jordan. My question to Professor Massimo, if you have any experience with the usage of oral methotrexate and other agents like rifampicin or aldactone, spironolactone, for example, in cases of recurrent CSR or chronic CSR. If you have an experience, I would like to hear it from you, please.
No, I don't have any experience with methotrexate or rifampicin. I have a very small experience with spironolactone derivatives like eplerenone, but now I don't use anymore also this kind of drug.
Okay, thank you very much, Dr. Mohammed.
This is the last slide of the case number 7, because it is important to show you this slide, because it is the last follow-up visit on March 2020, in which there is a particular pattern that is developing in the macular region, which is cystoid spaces within the retina. This is the beginning of posterior cystoid retinal degeneration, which is a degeneration of the retina typical of the late phase of chronic CSC. When there is, like in this case, the beginning of an RPE atrophy. You can see that here there is no outer layer anymore, there is no RPE anymore. There is a continuous between chora capillaris and the retina. So the fluid might diffuse freely from the chora capillaris directly in the intraretinal space and create cystoid retinal degeneration. And this is important to observe it, because photodynamic therapy is not very responsive in this case.
Okay.
And it's important to tell it to the patient. So this is the case number 8, actually. And this was the case in which I use only the imaging that you are seeing. Color fundus photograph, autofluorescence, and OCT. Why? Because this male patient had an anaphylactic shock during another visit in another hospital in another city for this kind of disease. So when he came to me, I decided not to perform again, of course, fluorescein angiography. But there was a problem, because there was a huge amount of subretinal fluid under the macula in the right eye as well as in the left eye. But there was fibrin under the nerve epithelium in the right eye as well as in the left eye. We were, I don't remember the year because it wasn't written, the year, but we were around 2010, 2011, and I decided to do half-dose PT. It was just an empiric decision. I have no clue of what to do, and I tried to do what was the best for me at that time, in both eyes, with a single spots on the macula. And maybe I was lucky, because the fluid completely resolved, as well as the fibrin, and is still in this, as you see, is still the same, completely resolved also after 5 years in both eyes. So this is just a slide showing you what I said the slide before about the posterior cystoid retinal degeneration. When you see cases like this, they are very unresponsive to photodynamic therapy. In those cases, you might try to do anti-VEGF. I think that those cases are the one most responsive to anti-VEGF in CSC, the one in which there is a cystoid retinal degeneration. Here is one case that I used to treat several years ago with PDT, with half-dose PDT, and you see that after 1 month, there was a big result, but after 10 months, there was again cystoid retinal degeneration in the macula. So case number 9, finally, some neovascularization, okay? So this is a typical case that now with the use of angio-CT, we are familiar to see in patients with CSC. Subretinal fluid, a flat detachment of the RPE, and the angio-CT showing us the quiescent, let's say, non-exudative choroidal neovascularization, which is no more than an occult choroidal neovascularization, the one that Iannuzzi described in the 90s, okay, with the use with the advent of the endosanguine angiography. So what to do in this case? I tried to do nothing. So I said to the patient, okay, you have this problem. I was not sure if doing anti-VEGF or half-dose PDT, so I decided to do nothing. I just performed the fluorescein angiography and endosanguine angiography. At the fluorescein angiography, the pattern was the one typical of a pinpoint leakage, so an occult choroidal neovascularization actually. Endosanguine angiography was not very informative. There was a very subtle, slight hyperpermeability of the choroid. I saw the patient after some weeks, and there was a partial spontaneous resolution of the subretinal fluid. But as you can see, neovessels were still there. Okay. I saw the patient again on April, but there was a recurrence. So huge amount of fluid under the nerve epithelium. The patient was symptomatic, but choroidal neovascularization was still there. No more, not less. For this reason, I decided to treat the patient with half-dose PDT, centered on the macula. And this was the results after 1 month after half-dose PDT. And this is after 8 months after half-dose PDT. Okay, so someone might ask me why subretinal fluid reabsorbed. Did it reabsorb for the effect on choroidal neovascularization or the effect on the choroid of the patient? To me, the fluid reabsorbed because I decreased the hyperpermeability to the choroid. There was no effect to me on choroidal neovascularization, and to me, the origin and the reason of the fluid was not due to the choroidal neovascularization, but to the choroid of the patient. And I think that choroidal neovascularization, this kind of quiescent choroidal neovascularization, was not exudative and was supplemental to a choroidal disease. Probably there was a reduction of the oxygen from a diseased choroid, and this kind of new vessels was suppletive, was new vessels, was friends new vessels that nourish the RPE and the neuroepithelium. So if you are stubborn and you want to close those choroidal new vessels, it might be probable to damage the patient, to damage the retina. This is my opinion, not only my opinion, but the opinion of other colleagues more expert than me. So this is the reason why usually when I see this kind of patients, I'm used to treat with half-dose PDT as my first choice of treatment. Then, if I have no response, that it might be, I start with the injections.
Okay, so Professor Massimo, the case you mentioned, it's one of the common cases we face it in our clinic. And the first thing we use it as a first line in such cases, chronic CSR with CNV, is the anti-VEGF. Because since we have no any access for the photodynamic therapy, so do you think that the anti-VEGF is a good option for such cases?
Well, I mean, I think so, because also in Italy, most part of colleagues are used to inject patients because they are not familiar with PDT. They don't have PDT, so it's easier to inject the patient than to do PDT. Okay. So I think that at the end of the story, it might be useful, but we don't know exactly which is the reason why the fluid we absorb. Okay. And I'm concerned about the fact that if anti-VEGF are able to close choroidal neovascularization, that might be damaging the retina of the patient.
Yeah, because still the use of anti-VEGF is some debatable subject. Yeah. Because sometimes we inject the patient and the patient responding very well, sometimes even from one injection. And some of the patients, they keep injecting them and still the CSR recovered after 2 or 3 months from the injection. So yes, still the role of the anti-VEGF is still debatable, but it's a good option in such cases when we have no any access for the photodynamic therapy. Do you prefer any special?
Can I ask you?
Yeah.
Can I ask you which kind of protocol do you use in these cases? I mean, do you use a loading phase?
Yeah.
Or just one injection and you see?
Okay. So it's a good question. Since we are not dealing with a CNV like the CNV found in AMD, so in those cases we don't have like studies about them how to start like in AMD, like loading doses. And also we treating a CNV with a pachychoroid disease, not like the CNV with the AMD. So, but in general, I start to give them, for example, 2 injections 1 month apart, and I keep monitoring them in every visit on the OCTA and to see a regression of the CNV. Once I found there's a regression and the subretinal fluid disappeared, then I will stop and the treatment will be PRN. Because still we don't have, like to say, there's no any special protocol for CNV in such cases, not like the AMD. I don't know if you prefer any special kind of anti-VEGF. One of the attendees asking this question, or it doesn't matter to give any kind of.
Of course.
Okay, ranibizumab. Okay, actually, I'm using ranibizumab and also using aflibercept. Both of them working very nicely in such cases. Okay, so before we go to the last 2 cases, any questions from the attendees? And from the colleagues? Okay, so we can proceed with the case 10.
Okay, this case number 10, is a bad case. The case that didn't work, the case that it was a nightmare for me. So this is a male patient that I saw for the first time on 2012. There is subretinal fluid, but there is fibrin. You can see clearly in the fundus photograph. You can see clearly at the outer nuclear layer, and also the pinpoint, the hyper autofluorescent pinpoint within the subretinal fluid are typical of the presence of fibrin. Fluorescein angiography showed an increase, let's say, an increase of fluorescence. In this case, I interpreted on 2012 this kind of hyperfluorescence as a leakage. Probably it was not a leakage. Probably it was just a staining of the dye within the fibrin. But I interpreted and I made a mistake. And for this reason, however, I was influenced in the treatment, because I decided to treat with photocoagulation. And I start to photocoagulate this point because I supposed that was a leaking point. But I made a mistake, and there was a complication, and there was the growth of new vessels from the choroid under the RPE and under the nerve epithelium. So there was a manifest and a classic choroidal neovascularization, which is this one a true complication of CSE that might occur. It might occur after this case that it was treated with photocoagulation, but also spontaneously. And the difference between the previous choroidal neovascularization is that this kind of choroidal neovascularization is not growing just under the RPE and just in a non-exudative way, but it was growing vertically, passing through the RPE and growing under the nerve epithelium. So this kind of choroidal neovascularization must be treated with anti-VEGF, with injections, okay? And I tried to inject the patient. Actually, I injected at the beginning with the bevacizumab with good results. But then, also because this patient was not from our area, was distant from our area, so he had many difficulties to reach our hospital. I start to treat him not in a continuous way, and this is the results. There was a disciform scar. So pay attention also to the complications. And the last case, half-dose PDT on 2012. This was the OCT before half-dose PDT, and this was OCT post half-dose PDT. So in this case, you have to advise patient that after PDT he won't recover the vision. Why? Because there is the granularity of the outer nuclear layer. And as you can see, after PDT, there is a thinning of the fovea. Okay? But this patient was happy because the vision stopped decreasing. So he didn't have any increase in vision, but at least he didn't also have any decrease of visual acuity. And he was happy. He was followed by us until July 2015, when he came back to us saying that he was starting to experience the metamorphosis. And as a matter of fact, there was a small hemorrhage, and there was again a choroidal neovascularization growing vertically under the nerve epithelium. Angio-CT showed very well the choroidal neovascularization. Again, in this case, we have to treat the patient with anti-VEGF. So those are two different kinds, there are two different kinds to me of choroidal neovascularization. The non-exudative choroidal neovascularization, the one that I show you in the first case, and the exudative cases of choroidal neovascularization, the one that we have to treat with anti-VEGF. And as a matter of fact, after injections, there was a very good results. Okay. So my take-home message is that in generally speaking, it is not advisable to wait too much to treat CSC. Because if you wait too much, you might you might be responsible to a difficult recovery of the visual acuity. So you need to, I used to treat earlier. And I'm used to do those kind of treatment. If acute, focal laser, if chronic, modified PDT.
Okay. So thank you very much, Professor Massimo. Just we want to summarize your very wonderful cases. So as you said, the best option in either the focal laser in acute cases or a photodynamic therapy in chronic cases. And in some cases of a chronic, if you have any fibrinous exudate, it's better to treat the patient by another options like the anti-VEGF until the fibrinous exudate completely resolved, and then you can treat him with the photodynamic therapy. And also the anti-VEGF is also a useful option in the cases of CSR with CNV. So just before taking the questions, I will present just one case in 3 minutes about the CSR. Okay.
Let me.
Yeah.
Okay.
Okay. So. Okay. I want to share. Okay. So.
Dr. Fawaz, can I ask?
Okay.
Or you start?
Yeah.
Okay.
Okay, it's okay. Now the presentation is okay.
I don't see the presentation.
Okay, let me check again. Okay, I will share. If any attendees having the question is, please, before we start, send this to.
Okay, Dr. Massimo, you said don't wait too much. How long is the too much?
Okay, that's a very good point. It depends. If I realized and if I'm sure that the CSC is the first event, is in acute, a real acute CSC, I wait just 1 month, not more.
Okay.
But as many times it happens that we see patients that are rounding many other kind of colleagues. So when I see those kind of patients with persistent fluid, I don't wait.
Okay, thank you, Doctor.
Okay, can you see my screen now?
Yeah.
Okay, thank you very much. So I will present a case, a little bit of a different perspective. Okay, just I want to make, okay. Okay. Okay, so this case actually referred to from one of my colleagues. It's a 45 years old male, medically free. He's a dentist, presented with decreased vision in both eyes of 8 months duration, starting in the right eye and then involving the left eye 2 months later. On examination, the best corrected vision was 20/100 in the right eye and 20/40 in the left eye. The anterior segment examination was normal, and the fundus, as you can see here, there is bilateral subfoveal yellowish deposits with some RPE changes in the perimacular area in both the right and the left eye. So at that time, I decided to start with a non-invasive imaging modality, and this is the OCT for the patient. And the OCT, we can see the presence of a subfoveal hyperreflective material and the presence of hyperreflective fluid here, some areas of neurosensory detachment. Again, I usually, when I do the imaging, I use the one line to see the choroid. And again, there is an increase in the choroidal thickness, here around 590 and 612. And there is also some areas of the neurosensory detachment. So the case was referred under the suspicion of like a case of the posterior uveitis, because the patient started to drop off vision in both eyes, and the look of the OCT was very aggressive, and also we have an increase in the choroidal thickness. So at that step, we were wondering whether this is a case of the posterior uveitis, some kind of posterior uveitis like Harada or something, in spite that there is no any optic disc swelling, or it is something different. So when I did the fundus autofluorescence, I found this this is hypoautofluorescent with alternating hyperautofluorescent tracts. This is a typical gravitational tracts that usually we see it in the cases of the CSR. So at that time, I was suspecting the chronic CSR in the patient. The patient was previously treated with steroids under the suspicion of the posterior uveitis, and he mentioned that the vision became much worse after treatment. He received a systemic oral steroids. But because he's a dentist and I want to be very careful, I asked for the general investigations just to be sure that there is no any elements of the posterior uveitis. I did the infectious screen and the general screen, and all of the investigations were negative. And I tried to confirm my diagnosis. I did the fluorescein angiography for this patient. And again, I was very quietly sure that this is a case of the chronic central serous retinopathy, because the approach in different cases, in both cases, would be much different if we suspect a case of posterior uveitis versus a chronic CSR. So the treatment option, I offered the patient at this stage to give him a micropulse laser, especially to treating this leaky points. But the patient initially refused, and he wanted to resolve his problem as rapid as possible because he's a dentist and he wants to work. So at that time, I don't have any access to the photodynamic therapy, so I offered the anti-VEGF injection. I give him 2 injections, 1 month apart, of the anti-VEGF, and this is just to explain the role of the anti-VEGF in cases of the chronic CSR. This is one of the nice papers that's published about how the anti-VEGF can change the choroidal thickness after the used in patients with a pachychoroid disease, especially the patients with chronic CSR. Unfortunately, I don't have the OCTA for the patient, but I did the OCTA. There was no any CNV. So after 2 injections, then I convinced the patient to do the micropulse laser, because I told him that you might got a recurrence since there's a leakage areas, and these leakage areas will continue to leak from time to time. And this is the photo or the OCT image after 4 months of treatment. This is before, and this is after 4 months of treatment of 2 injections of anti-VEGF and 1 session of the micropulse laser. The vision in the right eye improved from 20/100 to 20/30, and in the left eye from 20/40 to 20/25, with the improvement of the foveal anatomy and the improvement of vision. Just I want to, from the message from this case, is that the cases of the chronic CSR sometimes may be misdiagnosed or confused as the cases of the posterior uveitis. And you may find many articles about such cases. And this is one of the recently published papers by a group of our colleagues. Also, Dr. Monsaf Gerallat's one of the eminent authors in the uveitis. And they mentioned the case exactly similar to our case, and they suspect initially that this is a case of the posterior uveitis, and then by investigations it was a case of a chronic CSR. Just I want to finish with this case, and the aim from my case is that the multimodal imaging, it's a very important in order to sometimes reach the diagnosis, the perfect diagnosis of the cases of the chronic CSR. Thank you very much. If you have any comment, Professor Massimo.
Well, very interesting case. I didn't understand the OCT that you showed after treatment. Was just after 2 injections or also after micropulse laser?
Yeah, after I gave him initially 2 injections, 1 month apart, and 1 month after the last injection, I do the micropulse laser. Okay. So the results will be the 2 months after the last treatment with the micropulse.
It's a combo treatment.
Yeah, it's a combo treatment, because initially the patient refused to the micropulse laser. So I offered the injection, and I told him that the injections, okay, it works, but the effect will not maybe persistent, because still you have a leakage point. So the micropulse laser sometimes can offering a very good option, especially we don't have an access to the photodynamic therapy.
Well, in this case, this was a case not to treat with the PDT actually, because there was a lot of fibrin. So you had a very impressive results and a very good reabsorption of the fibrin. So it was good, very good.
Yes. Okay, any question from the colleagues, any comments? You can unmute yourself and ask. Okay, so I think we finished now. Thank you very much, Professor Massimo, for the very nice and wonderful presentation that's showing all the aspects of the chronic central serous retinopathy and the treatment aspects. Thank you very much, and I hopefully join us in future meetings about the retinal disease and imaging. Thank you very much, and thank you.
It was a very great pleasure. Thank you very much to
thank you.
Because I was honored to be here. Thank you. Thank you.
Thank you. It's my honor, and I am really grateful that you are presenting this presentation, especially from Italy in this hard time for us and for all the world. And I wish to thank also the Jordine Ophthalmic Society and the Novartis company for the arrangement of this scientific webinar. Thank you very much.